Thank you. I'm going to start letting people in.
Okay, thanks, Emily.
Okay.
Well, good afternoon, everyone, and welcome to Medical Grand Rounds. I'd like to, just before we get started, just a reminder that we will be sending you an email right after rounds. So please answer a brief survey. This will let us know that you were present today. As well, we ask you to please enter your questions in the chat at the end of the presentation. Our guest speaker today is brought to us by the Division of Dermatology, and we have Dr. Ivan Litvinov, the Chief of Division of Dermatology, who is here today to present our guest speaker. Ivan, the floor is yours. Thank you.
Thank you very much, Dr. Giannetti. It's a true honor to present Dr. Elizabeth O'Brien, one of our esteemed members of the division. Dr. O'Brien is an associate professor of dermatology who is fully based at the Montreal General Hospital and is best known for her subspecialty clinics in immunodermatology involving treatment of autoimmune connective tissue diseases, and as you will learn today, hidradenitis suppurativa. She is a past president of the Canadian Professors of Dermatology Group. She was a past president of the past regional director of the Canadian Dermatology Association for our province. She also was recognized by the Canadian Dermatology Association with the President Cup Award. At McGill's side, she served as an Osler Fellow and also was recognized by McGill University with a National Faculty Scholar Award. In 2016, she established a dedicated clinic for hidradenitis suppurativa at the Montreal General Hospital. It's one of the very few clinics in Canada, and that clinic has become recognized as a center of excellence to provide care and teach and research on hidradenitis suppurativa. She is co-developing Quebec Hidradenitis Suppurativa Community of Practice in collaboration with Laval University faculty to facilitate research and patient care on this disease. She has been an invited local, national, and international speaker at hidradenitis suppurativa meetings. She is a board member of Canadian HS Foundation, and which is dedicated to the treatment and research on the disease. And she is a co-author on several clinical research publications concerning this disease and co-author of recently published textbooks named A Comprehensive Guide to Hidradenitis Suppurativa. We're going to learn about this disease, which is becoming much more prevalent in our society, and I think many of us are seeing those patients, so it's a really special pleasure to have Dr. O'Brien educate us on this. Dr. O'Brien.
Thank you, Ivan, for that wonderful introduction. When Ivan asked me if I would be willing to speak at Grand Rounds, I told him I'd never pass up an opportunity to speak about HS. It is so under-recognized and our patients suffer terribly as a result that I feel it somewhat of a mission to spread the word and make other physicians aware of the disease. My disclosures are as shown, relevant to HS. The objectives are as noted in the invitation email. So what is hidradenitis suppurativa, and why am I speaking to non-dermatology medical specialists about a skin disease? HS was only defined in 2009 by a consensus group as an chronic inflammatory recurrent debilitating skin follicular disease that usually presents after puberty with painful deep-seated inflamed lesions in the apocrine gland bearing areas of the body, most commonly the axilla, inguinal, and anogenital regions. We know that it's an autoinflammatory skin disease, but the pathogenesis and the mechanisms of therapy are as yet poorly understood. We know that it involves the hair follicle or pilosebaceous unit and not the apocrine glands. They are innocent bystanders in the inflammation. We know that there is a genetic susceptibility. It involves an altered skin microbiome, and it also involves the innate immune system. More importantly, it has a significant impact on quality of life. HS is quite common. The prevalence in Canada at most recent estimate is 3.8%. The global range ranges from 0.1 to 7% of the population. It usually starts in the late teens, although it may start later into adulthood, and it often persists well into adulthood. It's more common in females than males in most populations, and in the United States, most studies have shown a predominance of Black individuals. About 30% of patients have a positive family history, and it is severely underdiagnosed. The delay from onset of symptoms to diagnosis averages 7 years. And this is because of a lack of recognition of the condition by patients and physicians, and also by patient embarrassment because of the purulent malodorous discharge that accompanies the disease. Many of them do not talk about the disease to friends, family, or their physicians. So why am I talking to non-dermatologists about this skin disease? That's because HS is often linked to non-derm comorbidities. And other specialties are important to us in collaborating in systemic management, and they can also assist in earlier recognition by recognizing HS in their patients. This is just a diagram showing the numerous overlaps with other medical specialties, including endocrinology, GI, rheumatology, general internal medicine, cardiology, and other non-medical specialists such as psychiatry and anesthesia. And we'll come back to this slide. HS is diagnosed by recognizing typical lesions, specifically deep-seated nodules or blind boils, often accompanied by fibrosis, abscesses, sinus tracts or connected follicles, and subsequent scarring, which may present in several forms. The typical locations are the flexural areas, axilla, groin, inframammary, perianal region, and buttocks, and it's characterized by relapses in chronicity, often several times over a year. A simple way to diagnose HS, and you could use this in your clinics if you suspect it in patients, is the following question, which would identify HS patients with a sensitivity of 90% and a specificity of 97%. And that is, have you had outbreaks of boils during the last 6 months with a minimum of 2 boils in any one of the following locations: axilla, groin, genitals, under the breasts, or other locations such as perianal, neck, and abdomen. This diagram just illustrates the commonly affected areas, again mainly the intertriginous areas, axilla, inframammary, groin, and perianal. Other sites that are commonly affected tend to be those sites affected by friction, so around the waistband, the inframammary, infra-abdominal fold, medial thighs, and the buttocks. Although HS can theoretically affect any part of the body. The typical lesions consist primarily of inflammatory lesions, tender, firm nodules, abscesses, and fistulae. However, the only pathognomonic feature is a non-inflammatory sign called a double comedone, where you have 2 blackheads or comedones closely spaced together. And this is diagnostic, but it is not included in severity scaling. Other lesions commonly seen are papules and pustules that look like acne, eroded or ulcerated nodules that resemble pyogenic granulomas, diffuse edema, particularly in the genital region, and large indurated fibrotic plaques due to interconnected fistulae. Scarring is a common subsequence of HS, and it may take the form of individual scars or connected scars, rope-like scars, superficial cribriform scars. Sometimes the scarring will affect an entire skin fold area or an entire anatomic region. The lesions, the individual lesions by themselves are quite nonspecific in terms of diagnosis, and there's always a differential diagnosis. There are many mimickers of HS, and this table just lists some of the mimickers of early lesions and mimickers of later lesions. And I had the pleasure, as Dr. Litvinov mentioned, of writing a chapter in the only to date textbook on hidradenitis suppurativa, and my chapter was on the differential diagnosis of HS. There are many cutaneous comorbidities also. psoriasis, pyoderma gangrenosum, acne. It's sometimes very difficult to distinguish acne lesions from HS lesions, dissecting cellulitis of the scalp, and also some inflammatory conditions presenting with different features. HS is graded for severity in order to establish disease activity, to manage treatment, to follow response to treatment, and for research purposes. The most commonly used severity gradings are the Hurley stage and the IHS-4, which involves counting individual nodules, abscesses, and fistulae. These are the two severity scales that we use routinely in our clinic. Other scales, which you will see in the literature, are more complex and more used for research. The Hurley stage, I mentioned, is the most common. That is the standard scale used for diagnosis and for research. And it involves 3 stages. First stage involves abscess formation, single or multiple, but without any sinus tracts and no scarring. Stage 2 involves abscesses with tract formation and or scarring, which may be single or multiple, but are widely separated. Stage 3, the most severe, involves diffuse or near diffuse involvement with multiple interconnected tracts and abscesses, which may cover the entire area. So the lesions are multiple and interconnected. This is a very simple slide of the pathogenesis. Pathogenesis 101. In a nutshell, HS involves follicular occlusion and dilatation. And this is due to a complex interplay of abnormal microbiome, abnormal keratinization, resulting in plugging of the follicle, leading to dilatation of the follicle, and eventually rupture of the follicle, which presents as inflammatory nodules and abscesses clinically. And then with progression, possibly a chronic state with interconnected follicles, scarring and fibrosis, which also involves the establishment of a biofilm within the fistulae. And these changes are due to a number of factors. A genetically susceptible individual who has an abnormal microbiome, and then further aggravated by a number of host and exogenous factors. The genes implicated in the pathogenesis of HS are primarily those involved in the gamma secretase pathway, which is important in normal immune system function and also in the maturation of hair follicles. There are a number of other genes that have been identified, and this is a case report that we published on a family, a father and 2 children with previously unreported variants of 2 genes. The actual pathogenesis is much more complex. It's a complex interplay between a follicular occlusion, altered microbiome, and abnormal immune reaction. Starts with the genetic susceptibility involving gamma secretase defects. There are also alterations in ceramide and sphingomyelin within the epidermis, and an abnormal microbiome with a skew in the normal representation of bacteria. These lead to activation of toll-like receptors, starting an inflammatory cascade with many common, well-known inflammatory markers, TNF-alpha, IL-23. It activates T cells, leading to further pro-inflammatory cytokines, with activation of the inflammasome, recruitment of macrophages, neutrophils, MMPs are also in there. There's release of caspase, micrometalloproteinases, and then further propagation of the inflammatory cascade. I mentioned the bacterial biofilm. This becomes established within fistulae and tends to promote further inflammation. There's also a feedback loop which keeps the whole thing going. And all of these factors can be aggravated by host factors such as hormones and external factors such as smoking. So coming back to our individual comorbidities and how all this relates to you as individual specialists. The validated comorbidities, it's hard to differentiate sometimes between comorbidities and risk factors, so I've grouped them together, are on this list. But there are a number of more recent ones that have been proposed but not yet validated. And we'll look at some of these in detail. Many patients have overlaps with inflammatory arthritis. We always inquire about joint pain in our patients. And based on meta-analysis global population studies, the prevalence of psoriatic arthropathy is about 0.3% in HS patients, compared to up to 0.25% in normal populations. Spondyloarthropathies are also fairly common compared to the normal population, with prevalence ranging in different studies up to 28.2%. Rheumatoid arthritis appears to be less common, although it's still fairly significant, up to 4.8% in HS compared to up to 1% in normal patients. There's definitely an overlap with HS and some of these rheumatologic conditions in what we call syndromic HS syndromes or syndromic acne syndromes. The top 5 are syndromes that involve HS. The bottom 5 involve acne, although, as I said, sometimes it's difficult to distinguish a superficial phenotype of HS from severe acne. And some of the earlier studies probably did not distinguish between the two. But the major syndromes that involve joints, sometimes ankylosing spondylitis, other cutaneous comorbidities are the top 5. There was an interesting recent whole exome sequencing study looking at conditions with syndromic HS and looking at the overlap between joint inflammation and gut inflammation. And in PAPASH, there's actually both. Trying to correlate the genotypes and the phenotypes. We can see that some of them are known, the gene relationship is known. However, in a number of other conditions, the variant or the significance is not yet well defined. A patient that I presented recently at our Canadian Dermatology meeting, I titled the presentation PASH, PASS, what's in a name? Was this patient PASH? Was he PASS? Well, the importance in defining what syndrome the patient actually has, it has import for the patient in terms of genetics. What is the family history? Many patients ask about transmission of HS and comorbidities to their family members. What are the comorbidities? What do we need to screen for in these patients? And it also has treatment implications. There are a number of variables within the inflammatory cascade that can be targeting, and perhaps knowing what the specific gene and gene product are may help us to choose selective treatment. There is significant overlap with gastroenterology, particularly Crohn's disease. The risk of Crohn's disease in HS has been estimated at 3 times over the normal. Some studies adjusted odds up to 2 times, and the prevalence is up to 2%. Ulcerative colitis is generally less commonly associated with HS, with a prevalence of up to 1.3% and odds up to 1.8%. There are a number of similarities between HS and IBD in terms of the clinical presentation of the disease. They both involve a dysbiosis, abnormal microbiome, one of the gut, one of the skin. The age of onset is similar. They have similar increased comorbidities, including psoriasis, pyoderma gangrenosum, and inflammatory arthropathies and spondyloarthropathy. They're both worsened by smoking and obesity, and we do use similar treatments, including antibiotics, anti-TNF, and other biologic agents. Excuse me. Both IBD and HS have significant impacts on patient quality of life. Excuse me, in terms of, and which are measured by individual patient-reported outcomes. We use the DLQI in dermatology, and gastroenterology has a similar quality of life scale. The physical impacts are important in terms of fatigue, partly due to anemia, pain, and there's important psychological impacts due to the fact that they are both chronic and relapsing diseases, which increases anxiety, depression, risk of suicide. They both have concerns about discharge and odor, and have impact on body image, which impacts their personal and sexual relationships. Patients in both diseases often have concerns about genetics and reproduction. Comorbidities related to endocrinology are frequent. There's an increased risk of diabetes in HS up to 2.8. Metabolic syndrome, many of our patients are obese, and there's an overall prevalence of 3.5 compared to normal. Metabolic syndrome specifically up to 2.2%. We always inquire in female patients about the possibility of polycystic ovarian disease, and there is an increased prevalence up to 4% compared to the normal population. The risk in HS patients of developing having PCOS is up to 2.4, but with a wide range depending on the study. One recent study showed a correlation between BMI and serum levels of leptin resistant in HS patients. And their conclusion was that the serum levels of adipokines are dysregulated in HS and are associated with obesity. Recent studies looking at impacts on cardiovascular disease have shown an increased risk of primarily myocardial infarction, less with CVA and peripheral vascular disease. But the risks for MI seem to be possibly higher in females, although the age and sex-adjusted risk was slightly lower, but highly significant. And this is a table from that study showing the difference in cumulative incidence of MI in HS patients versus control patients. I've mentioned the altered microbiome. Normal skin microbiome consists of 5 groups. In HS, it seems that groups 1 and 4 predominate. And this is a pretty chart showing, you can see the difference here of the Propionibacterium acnes, which is minimally present here, and we see proportionately a greater number of Porphyromonas species compared to the normal microbiome. Hematology, we don't often refer patients to hematology, but we know that many patients with HS are anemic. Most of our moderate to severe HS patients are anemic. One large study which controlled for BMI and HbA1c showed an increase rate of anemia overall of 2.73. And they found a greater difference in males compared to females. One of our residents, as part of a master's program, looked at our patient. We now have over 300 patients, but of 104 patients where we had looked at anemia, we found that there was an increase, there was a rate of 28.9% of these patients who were anemic based on these criteria. And we found an increased risk in increased disease severity, patients who had diabetes, and in Black patients. The psychological comorbidities I've mentioned, certainly anxiety, depression, and schizophrenia have been identified as independent comorbidities in patients. Suicide rate is several times normal. Substance abuse and sexual dysfunction are all both comorbidities and some consequences of the disease. And as a result of these problems, it has been shown, and one of our former residents did an isolated study on work productivity, confirming that patients with HS have lower productivity, lower rates of employment, and they also have poor relationships in general. Patients with HS with chronic disease often develop both nociceptive pain associated with acute lesions, but also chronic neuropathic pain. So we sometimes refer to pain clinic or use management for chronic pain. The medical therapy of HS, looking at all these comorbidities, is naturally very broad. We use a variety of systemic medications, including antibiotics, retinoids, anti-androgens, immunosuppressives, and others, anti-inflammatory and metabolic. The overall approach to the management of HS was most recently and very completely and concisely summarized in this paper, which I had the pleasure of being a co-author. And this is just one of the tables from that paper, where we based the approach on the severity scaling, so Hurley 1, Hurley 2, and Hurley 3. You can see that many of the same modalities are used from stage to stage, and what we do is we add on. If the patient progresses or is not responding, we don't necessarily stop the basic management, but we add to it. It's obvious in treating patients that there's no one treatment that will control the disease effectively and completely. Most patients require a combination of multiple modalities. Also down here, I have not mentioned surgery. because of the nature of this presentation, but surgery is a very important modality to excise chronic lesions, and we do small surgeries in our clinic, deroofing or excision of small lesions, and we do refer a number of patients with more extensive disease to plastics, colorectal, or general surgery. Antibiotics are generally the mainstay of treatment, and we use them not just as antibacterial agents. Yes, there is an abnormal microbiome, but also as anti-inflammatory treatment. The tetracyclines are known to inhibit matrix metalloproteinase, and doxycycline has been shown to be much more effective than other tetracyclines, partly because of its affinity for zinc. It's more effective against active MMPs, latent MMPs, and against reactive oxygen species. So our go-to antibiotic, what we often try first, is doxycycline. And doxycycline is also used for periodontal disease, which interestingly has one of the organisms that we identified in the HS biofilm is a key player in periodontal biofilm. And in periodontal disease, often use sub-antimicrobial doses. We tend to use full doses, partly to mitigate against poor absorption of the doxycycline. So this is a table showing the various antibiotics that can be used with HS. Again, doxycycline is our main go-to antibiotic. Clindamycin, with or without rifampicin, there are studies showing that clindamycin as a monotherapy may be as effective in HS as clindamycin with rifampin. If the patient tolerates it, we often use the combination on the basis that the rifampin is more effective against biofilm. Other combinations have been reported. Our big gun is ertapenem for patients with severe out-of-control disease, or as a rescue treatment, or to bring the disease under control prior to a planned surgery. IV ertapenem given for 6 weeks, followed by oral consolidation therapy, is dramatically effective. However, it is regarded as a short-term rescue therapy. Recently, similar effects have been shown with mirtapenem. I do not have experience with mirtapenem, but we have treated a number of patients with ertapenem as a rescue therapy. Because of all the inflammatory agents, cytokines involved in HS, we use biologic therapy for moderate to severe disease. The only drug that is officially approved is adalimumab, now being replaced by biosimilars. All the others are off-label. But among the anti-TNFs, adalimumab is usually our first go-to. Infliximab for patients who don't respond, or if we want to dose on because of obesity. Second-line choices include ustekinumab, although we use Crohn's dose. It's very common in HS that the patients do not respond to the doses for arthritis, for psoriatic or rheumatoid arthritis. They need higher doses. So we generally bump up to 80 milligrams. We use the higher dose of IV infliximab. Recently, I've been starting patients off the bat with Crohn's dosing to get response. Others that we have used in a few patients, secukinumab, and I recently applied for guselkumab for one patient. So this is just a nice little table summarizing the agents that have been reported for HS. Some of the newer ones, including brodalumab and bimekizumab. There is some evidence, but they're not widely in use as yet. So I'd just like to finish up with a brief case history. Some of you may recognize this patient. You can see that he has very extensive disease, but with typical locations involved. And these large areas of scarring are actually due to one of the cutaneous comorbidities, pyoderma gangrenosum. This is a 47-year-old male who was born in Mauritius. He developed acne in his teens, developed early stage 3 HS in his 20s, developed pyoderma gangrenosum more recently. He was diagnosed with ankylosing spondylitis and a peripheral enthesitis synovitis in 2016, which is HLA-B27 negative. He has diabetes type 2 but is non-obese. He has hyperlipidemia. Incidentally has peptic ulcer and diverticulitis, and incidentally possible bartonellosis in the past, which is not a comorbidity but interfered with his treatment because we were reluctant to give anti-TNFs. He has no known family history. He's been treated previously with sulfasalazine but developed thrombocytopenia, cyclosporin. Accutane caused elevated liver function tests. Colchicine caused cardiomyopathy and intolerable GI side effects. Doxycycline was intolerable because of GI side effects. He was on Cosentyx for several years, but gradually it lost efficacy. And we see this commonly in HS patients where usually within 2 to 2.5 years, even with fairly good response, they lose efficacy to the biologic therapy. We applied for guselkumab, but it was refused by the company because of inadequate data on HS, and are pending approval of ustekinumab, both for his joints and his skin, which flared severely. The pictures that I showed you were actually taken after a return from a vacation where he had been put back to Mauritius, where he had been put on high-dose prednisone, I believe 50 milligrams daily of prednisone, tapering down to 20 when we saw him. So all of this, when we saw him before his trip, was red, swollen, painful, and now we see mainly post-inflammatory hyperpigmentation. So this case easily illustrates the interplay between various medical disciplines and the need for collaboration. So because of the delay in diagnosis and the subsequent scarring and impact on daily life, it's very important that patients are diagnosed early and referred to dermatology for management. We need the help of the medical consultants to manage the comorbidities that are beyond our expertise. We want to optimize control disease, and this also optimizes surgical outcomes. Surgery is an important modality, but the results of surgery are much better if the inflammation is controlled, and surgery generally will not accept patients who have uncontrolled inflammation. They bounce them back to us to manage the inflammation first. So what can you as medical colleagues do to help patients with HS? Well, I would ask you to consider HS when you see patients with these comorbid conditions, and ask about signs and symptoms. The fastest way is to ask the question that I showed earlier about having lesions over the past 6 months. If possible, learn to recognize the signs and symptoms of HS so you can identify them when you're examining patients. By all means, refer to dermatology, and I say this with some trepidation because we now have close to 100 patients on our wait list, but by all means, refer to dermatology, even to community dermatology who can assess and start treatment. And yes, we definitely value your help in co-managing patients with all these various comorbidities. And I would just like to acknowledge the Canadian Hidradenitis Suppurativa Foundation. We're a group of dedicated dermatologists who are working to improve HS for our Canadian patients. We're also linked with the American HS Foundation. And there is an upcoming meeting for those who are interested, Symposium on Hidradenitis Suppurativa Advances, which is a collaboration between American and Canadian dermatologists. Thank you, and I'd be happy to answer any questions you have.
Thank you so much. This was a fascinating lecture that really touched, as you said, all of us, I think in medicine, so many specialties involved in taking care of these patients. I invite people to enter questions in the chat. Just a quick question before I look at the chat. In that last slide, you said to, try to look for HS in people who may present with comorbid conditions that one could have with HS. How often do patients present sort of with other issues and not the dermatological? How the case you showed us is obviously very extreme, I guess, dermatological condition that is very obvious, but how often is it that somebody presents with another inflammatory kind of problem and then you find HS afterwards?
It's probably very common. We know that patients that we see who are undiagnosed have seen multiple physicians over the years. And again, it's partly the problem that the patients don't disclose the problem out of embarrassment to physicians, or that they don't make the connection, say, between their arthritis and their skin. So it's often the onus is on physicians to specifically ask patients about skin disease.
Thank you very much. Questions in the chat. Ariel Mendel is asking, are there any established RAMQ criteria for approving anti-TNF? Example, what drugs you have to try first, or are there severity criteria?
Yes, there are no hard and fast criteria. However, generally the patient has to be Hurley 2 to 3, so moderate to severe. They generally have to have failed clindamycin, so doxycycline if they can take it, clindamycin and rifampicin. Generally at least a 3-month course. Oftentimes now the RAMQ and private insurance companies will ask for specific lesion counts. And we now note these on our charts, including the number of nodules, number of abscesses, and number of fistulae. So we routinely document the Hurley scale and the IHS4 when we're applying.
Thank you. Sashna Bernatsky wants to know, are recurrent boils in the areas you specify without those features of coalescence and scarring potentially part of the same spectrum, being a mild HS disease perhaps?
Absolutely. It can be difficult to establish the diagnosis in early disease when patients are getting maybe 1 or 2 boils every few months. And sometimes it's only over time that we can establish the disease. So we look in all affected areas, look for signs of scarring, and for the double comedones. I was referred a teenager, 18-year-old recently, who had a history of small recurring, possibly acne lesions, but on examination he definitely had double comedones in typical areas. So our conclusion was that yes, he was a very early HS.
You mentioned that there's a higher risk of myocardial infarction in these patients. Can you maybe tell us a little bit more about that? Is it just inflammatory? Is there a thromboembolic phenomenon that's going on? What do you know about the association between the two?
It seems to be more inflammatory and largely linked to metabolic syndrome. Yeah, there doesn't seem to be an increase in thromboembolic events, but there is definitely increase in early atherosclerosis in patients that has been documented.
Okay. So something to consider if a younger patient perhaps presents with a myocardial infarction sort of for unexplained reasons.
Yes, absolutely. Yeah.
That kind of event. Okay. Fantastic.
Mhm.
I don't see any other questions in the chat right now. So I think I just last little comment. So if we see patients or we suspect, do we just refer them here at the MUHC to dermatology in general? You mentioned there's a 100 patient wait list. Is this something that you would consider sort of a more urgent referral? And how would we go about doing that?
If they're severe, yes, although I found it impossible to triage on the basis of urgency because many of our patients have had their disease for many years and have severe disease. So what we have been forced to do is just accept and triage on the basis of the date that we receive. However, if they have mild disease, that can be managed by a community dermatologist. So if they have mild disease or if you're not sure of the diagnosis, I would recommend referring to a community dermatologist first to establish the diagnosis.
Right. And I have a meeting
them on treatment.
in a moment here.
But certainly any patients with severe disease, community dermatologists will inevitably refer to us. So you can refer directly to the clinic.
Fantastic. Well, thank you very much. Really, a really interesting talk, a very, very interesting topic that we don't hear about very often. And as I mentioned, that touches many of the disciplines in the Department of Medicine. So thank you so much for sharing this with us and for being here today. And thank you to all our attendees for being here today as well. I wish everyone a great afternoon. Thank you. Bye-bye.
My pleasure.